thank you, Professor Marar, for inviting me to lead this, to share you and leading this session. Thank you, Professor Sonia. I would like to we would like to start our second session today, entitled Concerns in Practice. And we are happy today to have Professor Walid Youssef and Professor Ashraf Hagami, professors of anesthesia in Shams University. Thank you for sharing with us this important session. And please start. Thank you.
Let me at first express my appreciation and gratitude toward the chairperson as well as to your excellence. We are going to just highlight some concern in the management of critically ill elderly. I am Walid Youssef, Dr. Ashraf Al-Agami.
Good morning. Thank you for inviting us to share in this meeting. Really, when we discuss this topic with Dr. Walid, I think it is more or less easy topic to discuss, as we don't have so many elderly people, especially in Egypt.
Sorry, Dr. Ashraf, but actually elderly representing like 10% of the whole population all over the world, with estimated ratio like 25% of a lot of society. Here in Egypt, the estimated elderly population is like 6% of the population.
Really, we can deal with the patients in the ICU, the frailty patient in ICU, as ordinarily adult patient. There is no special concern for them.
Unfortunately, it will not be like that, Dr. Ashraf. Elderly has a special issue in management in critically ill situation, especially those patient group have multi-morbidity. This multi-morbidity puts those patients at a high risk of long and short-term complications.
About the term frailty, I think, Dr. Walid, it is only a psychological problem or nutritional problem, but we don't have so much deal with these patients in our practice in intensive care.
Frailty have a special issue in the management special issue in the management of critical ill patient. Will not go through frailty more because it's discussed too much today. However, frailty is during stressful condition have an impact on the patient. During stressful due to decline in their physiological system, those patients will not be able to face stressful event as non-frail elderly.
And the central nervous system affection for this patient, there is no so much changes than the adult patients.
No, Dr. Ashraf, usually there is increased blood-brain barrier permeability, increased gray-white matter volume, and the increased risk of delirium. Increased risk of delirium, we have to work by preventing delirium through adopting ABCDEF bundle protocol, so it may help in prevention of delirium. Here we have the precipitating factor for delirium. We can estimate those patients at a high risk for delirium, and accordingly we can adopt preventive protocol for those groups.
If I agreed with you in the delirium of the old-aged person, but I think it is very easy to manage these patients regarding delirium.
Management is okay, but prevention is much more better than management carrying a good outcome or than management already patient manifested by delirium. We can also use pharmacological adjuvant for prevention of delirium. Here is some research work highlighting the role of prevention for delirium and how preventive bundle could help in preventing delirium. And the role of pharmacological adjuvant, we have many research done in this regard by adopting a small dose of quetiapine or haloperidol. It could prevent in prevention or could help in prevention of delirium.
affection of the CNS, if I agreed with you, affection of the CNS is okay for this type of patients, but other systems like cardiovascular system, there is no much affection.
There is affection, Dr. Ashraf. Those patients have increased resting sympathetic tone, decreased myocardial and vascular relaxation, and their fluid management should be treated in a wise manner. They are preload dependent and they are sensitive to the volume changes.
The static measures, I think, is enough for these patients, Dr. Walid. Static measures for the cardiovascular system.
The static measure is okay, Dr. Ashraf, but it is not as reliable as we mean by static measure, like non-invasive blood pressure, like urine output, like CVB or central venous pressure measurement. However, they are not as sensitive as dynamic indices to assess fluid responsiveness.
If this kind of patients are mechanically ventilated in ICU, really it is very easy to me to be weaned from mechanical ventilation.
Before we going for mechanical ventilation, let me discuss what I mean by dynamic indices for volume responsiveness. Dynamic indices for volume responsiveness, including pulse pressure variation, stroke volume variation assessment. This is a matter of a device. We can get a reading from the machine by the value, and accordingly we can judge to resuscitate or not to resuscitate. Also, like passive leg raising test as shown here, index respiratory occlusion test is a matter of the function of echocardiography, carotid flow time. As shown in the first figure, it's calculated by certain equation using ultrasound and change in the inferior vena cava diameter. It makes a difference whether the patient is ventilated or spontaneously breathing.
Again, if the patient is ventilated, it is easy to be weaned, and the respiratory system is not much affected as the central venous system for them.
Unfortunately, it will not like a piece of cake, Dr. Ashraf. Better to avoid ventilation for those patients due to associated sarcopenia and muscle wasting and the functional decline in the lung capacities. So those patients, the weaning from mechanical ventilation will be challenging. So we have to judge weaning from mechanical ventilation as multiple trial increase the risk of morbidity and mortality by using certain indices like rapid shallow breathing indices, like using ultrasound to scan the lung. We have different image to show there the difference. If we have a score 0 by ultrasound, so this lung parenchyma is okay. If we have a score of 2, it means that we have multiple issue in the lung parenchyma, so we cannot go for weaning at the time being.
What do you mean, Dr. Walid, by rapid shallow breathing index? I think mechanical weaning from mechanical ventilation is more or less according to the clinical more than the ventilatory pattern.
We cannot ignore the role of clinical judgment, Dr. Ashraf, in the weaning from mechanical ventilation. However, whenever I have a figure, it's much more better than just judge. You can see, like, if I saw a patient, he is anemic. Yes, he is anemic. It's a clinical judgment. But whenever I have a CBC with a hemoglobin, with a figure, so I can better judge for those patients. Exactly the same here. We have a rapid shallow breathing index, a matter of frequency over tidal volume. So I have a figure. According to this figure, if this is less than 100, this means that this patient, we can predict that this patient will be winnable from the mechanical ventilation.
If I wean these patients from mechanical ventilation, I should wean also from the ICU, so the patient better to be discharged to ward.
Let me highlight before weaning from the ICU that assessment for fluidity is mandatory, like SOFA scoring in the ICU. So every patient admitted to the ICU should be screened for fluidity. Clinical fluidity scale is the most accepted in the ICU setting, and we are looking forward to have a smaller scale like that done by Freddy Toll based on 5 criteria. This will help a lot if we try to do one like this for critically ill patient.
If these patients is discharged from the ICU, I think
If you
really-
please, one again, we have a predictor for biomarker predictor for frailty like proadrenomadalin and copeptine and various cytokines. It may help to prevent or predict those at a high risk of frailty, and this will change the management plan for those patients.
But this is, I think,
I know
very
it's
expensive.
yeah,
Yes,
but
yes.
we can try to.
Okay. If this patient is kind of patients discharged from the ICU, I think their families will be very happy to have these patients again to their home.
Sure, they will happy, but it's challenging for them because usually patient discharged with what's called post-intensive care syndrome. Post-intensive care syndrome put a challenge on the patient and the caregiver and have a negative impact on the caregiving for those patients. Post-intensive care syndrome usually presented by anxiety, usually presented by depression and trauma-related risk factor.
Why depression? This
I don't
patient
know
will be
why.
depression. I don't think these patients have depression. They are discharged from the ICU. They will be happy, and their relatives also.
Unfortunately, the incidence of depression whenever they are discharged from the ICU, the first day is like 16%, and it be as high as 70% 3 months later. Anxiety is as well, prevalence rate is 80% during the ICU stay and decreased to 15 to 24% 6 months after ICU discharge.
When these patients discharged from ICU, they should have special care in their homes.
They should have a special care regarding the assessment and the management of post-intensive care syndrome. And many centers require a psychologist to be engaged in the management of those patients, especially in the early 6 months. The patient during their stay, after ICU stay, put a great impact on their caregivers as all of them become sleep deprived from the manifestation associated with the post-intensive care syndrome. And this will have an impact, again, negative impact on the caregiving for those population at this high risk time gap.
Yes, I think their families will be very anxious about readmission again to ICU. How can we prevent this, Dr. Walid, by the special care?
So we have to, as I said, Dr. Ashraf, we have to engage a psychologist and geriatrician in the management after ICU stay. Their illness is not ended by being discharged from the ICU. We are starting a new interval in the management of those patients. So finally, let me put some recommendation for a critically ill patient in the ICU. Frailty index is an important item in the scoring like SOFA and the other score during the ICU station. We have to put a timing and the scale our timing for the frailty score to be done in the ICU. Whatever we need it every 2 to 3 days or as it indicated. Frailty level should be integrated according to the school in putting a treatment plan during the stay in the ICU. Dynamic indices should be applied in the fluid management of the elderly critically ill patient. We have to go through bedside ultrasound for weaning of those patients and applying respiratory index. Screening for geriatric syndrome and considering in the risk assessment of those patients.
Really, you convince me, Dr. Wali.
Thank you, Dr. Ashraf. Let me say, aging is not a lost use, but a new stage of opportunity and strength. And let me thank you all.
Thank you.
Thank you, Professor Walid. Thank you, Professor Ashraf. Very interesting talk. And actually, you did highlight very important point in our practice. Any question for both for Professor Walid and Professor Ashraf?
Thank you.
And Dr. Mohammed, تفضل.
تفضل. Actually, ICU stay put an expenses on the healthcare system and on the healthcare provider as well. We are looking forward to have a certain criteria for admission of the patient. As shown in this presentation, we have too many issues from ICU admission. So those to be admitted should be highly selected, not especially it's a chronic illness and will not be relieved by ICU stay. So it doesn't matter to put this patient all over their life in the ICU. So we have to select from those patients who are in a true need for ICU stay. True need for ICU stay, I mean those who have an impact on their respiratory function, or they have an impact on their cardiovascular system, or other impact like this, which put a true danger on the patient's life. Okay, thank you.
Really also, not only agitation, we see so many old age geriatric patients admitted to ICU due to agitation only, without any other comorbidities. And agitation is increased when the patient is deprivated from his family. As said by Dr. Walid, very important to assess the whole general condition of the patient, not only one thing, hemodynamics and the respiratory system and imaging before admission. Not all elderly patient admitted without a specific cause.
Okay, thank you. Thank you.
Bismillah ar-Rahman ar-Rahim. I would like to thank Dr. Walid and Dr. Ashraf. Thank you very much. And I introduce my dear colleague, Professor Mohammed Shawqi Khater, will talk to us about potential therapeutics in frailty.
Thank you very much, and great pleasure to be with you today. Well, I'm going to talk about an important topic for us. We all know the frailty quite well, and we all aware about its consequences for our patients. I'm going to talk about the potential therapeutics. Well, from your expectations, as you are all expecting, there is a plan to be done, personalized plan to be done for every patient. This is the main line of treatments for frailty. There is no one classical scenario. It's different from a patient and another. And as we all know that this comprehensive approach is the main line of treatment. So if we can find a medication that can treat frailty, I'm expecting that we are finding medication that is treating aging. So we reach an anti-aging medication. I think that it's really very precious to find. As we all can imagine, that frailty goes in a line, and in another direction, opposite direction, is the resilience. When we all facing the stress, how can we overcome this stress? How our resilience will face the stress? The resilience may be at the cellular level or even at the functional level. A cellular level, a cell can stand the stress of heat or chemotherapy or toxins. At the more organ level, can a person with a dementia risk and even have a gene or amyloid plaque deposition in his brain, all his cells is against his cognition, can he still cognitively intact? This is the resilience. And yes, it is present. And as you all know, that MRI findings of typical Alzheimer's disease patients, the patient may be clinically not diseased. You got this concept? Keep in mind. No need to say a lot of diagrams. I want to discuss another concept about the muscles. You all know that our muscles are very dynamic. It can be changed quickly. We can choose to be like this model if we train it. If we train it with anabolic, we will go to this, the Ferris model. If we train it with aerobic, we will go for this successful aging model. But if we go the classical scenario, we will go to a very unpleasant picture. So another point to be considered, frailty is equivalent to aging, and frailty may be preventable or not. From your point of view, is it preventable or not? If we can say that the tip of iceberg, we can see that aging is associated, frailty is associated with aging syndromes. Well, at the upper of the water, we can see that these age-associated problems, and there is a nutritional issues in the frailty. Deep inside, there is a lot of cellular mechanisms. No need to enter in these details. And at the end, frailty is complex, and we all know that these details, and it has its impact on the social and psychological state of the person, like Professor William have just mentioned. And this interaction play an important role for prevention of frailty. Let's give this small example. As we all know that with aging, we are going to reach our maximum muscle performance at the mid-age. Then we are going to have steady decline in the muscle mass gradually with time. As we get older, we have two scenarios. The upper one, this is the successful aging scenario. The lower one, it is a frail scenario. But we can see that there is a lot of things play an important role, like the inflammatory process and the disease that we may develop over time. So if we go back to this scenario, the tip of the iceberg scenario, we can see that there is a lot of fixed domains we cannot play with it. Our genes, how our cells are dealing with our stress, but there is a lot of variable domain we can have an impact on it. Like the anabolic stimuli for the muscle. As we all know that we have anabolic resistance with age. When we eat and when we do exercise, we are expecting our muscle mass to be better. So this is frailty if we don't respond well to nutrition and exercise. So this will take us to the direction of frail elderly. And this is an important pathology of the frailty, the anabolic resistance. At the lower one, a person is experience nutrition, and the other one is experience the same amount of nutrition. The younger one have a better muscle mass than the lower one. And the anabolic resistance play an important role in the frail elderly with a lot of mechanisms, like you can see. But what really matters is these issues. we were believing that this anabolic resistance is present only in elderly, right? This is a young person who has been in cast due to fracture bone, and you can clearly see that there is a differentiation between the left leg and the right leg, and it is obvious that the left leg, if the leg has been in cast. So why this older person developed the anabolic resistance? Why this young person developed the anabolic resistance? Why he developed this aging process? What's the main pathology? It's the lack of physical activities, right? There is a great possibility that our genes and the cellular mechanism that is present in our body is a constant factor. And what we have in our hands is the important factors. Our physical activities, our nutrition, how our dealing with stress, these play an important role in the frailty. There is a theory said that we may be aged and we may be losing muscles because we are experiencing attacks of inactivities during our course. When we age, we may get sick and we will get bed-bound or less mobile, so we are going to experience muscle losses quickly. What's interesting in this point is that it can occur at any age. That's why this study is very interesting. In the first curve, they mentioned this is the anabolic resistance. And this is in the, when the elderly person have been taking the protein diet, they have low muscle mass. And we can see this even in the post-ICU patients, right? But when we add exercise, even electric stimulation of the muscle according to the patient state, we were able to defeat the anabolic resistance. No need to enter in these details. So how we can test this person is frail? There is a lot of biomarkers that can be measured, but mostly the biomarkers associated with inflammations are those who are responding for aging, are those who are responding for sarcopenia, are those who are responding for frailty. So of course, we are going to experience changes in the biomarkers and telomere alterations and shortness. I want to talk about the recent lines in the therapy. There is two main medications would be available: the senolytic medication and the xenomorphic medications. These are the medications that works against the senescent cells. In the senolytic medications, we are expecting the medication will be act to the DNA, to the replications of the cell. We want to stop the cells from being replicant. We want to stop its replication. Which cell? The senescent cell only. So in this line of therapy, the main issue is stopping the old cells. In the other types, the xenomorphic intervention, we want to stop the inflammatory mediators that happen with the cells. So in the first example, we are dealing only from inside of the cell, the senolytic medication. And the xenomorphic medication line, we want to stop the inflammatory process. Which better from your point of view? Stopping the cell from replications or stopping the inflammatory process? Of course, stopping the cell from replication. You know why? Because you are going to only targeting the old cells. And you don't have to give the medication for a long time. But if you are going to deal with the inflammatory process, you have to give the medication for a long time. So you have to measure its level, and the elderly person will be exposed to its serious side effects, which is the contrary opposite of the senolytic medications. That's why the future is in the hit and run. Give senolytic medication and go back quickly. Another important issue in the senolytic medications is that it can deal with the senescent cells if it changes its morphology and going to the tumor way direction. We have another point against the xenotropic medications is that it's not 100% sure that the inflammatory process is the main problem with aging. The only thing again is the senolytic medication, how we are going to give this huge amount of drug in very old person. He has a lot of senescent cells. I was expecting that these lines of treatment will be very expensive. However, the flavonoids, the quercetin and the fisetin. These are present in the apple and bananas and blueberries and cucumbers. With a high dose, it has been proved that they are senolytic. However, dasatinib is a medication used to treat the leukemias, myeloid leukemias, and it is in oral form. And it has been well studied, and its safety margin is very high. This is why the combination of these anti-leukemia cells and these flavonoids has been studied aggressively as an anti-aging medicine. And their results have been, there are still a very good results, and it has been in early stages with the clinical trials. James Kirkland, one of the most famous anti-aging doctors, and his team in Mayo Clinic, they are interested in these three combinations, and we are expecting good results within the coming years by them. Other scientists examined the effect of these medications for age-related diseases, like idiopathic pulmonary fibrosis. When given these three combinations, they find that it has a better results for the patient functions. There is still challenges, and these medications are still under the research. There is a lot of other medications, and if we can see, we will find the leucine, the metformin, the ACE inhibitors. There is a lot of other testosterone, growth hormone, a lot of medication that can be managed as senolytic medication. The future is going with the senolytic medication. From this, in our geriatric medicine, we want the geroprotectors. The geroprotectors are the senolytic medications associated with anti-aging. And this is the future of the treatment of frailty. Another pathways we may experience the gut microbiome. We all know that the gut microbiome play an important role for different parts, the short chain fatty acids that's released from them, important for our inflammation and cognition, muscle mass, our physical performance, insulin resistance. So changing this gut microbiome with prebiotic or probiotics, prebiotics giving the lactobacillus by itself, or probiotic or symbiotics, both of them will be another future for treating of muscle mass problems. Epilin is another example for treating the anabolic resistance that we have mentioned in the beginning. Another example, practical example, is the caloric restriction. Caloric restriction play an important role in the inflammatory process, and it is easily done and still giving better results. Nutritional intervention like Mediterranean diet, ketogenic diets, playing with the immune system, play an important role. What really matters is how early we are working. If we work early, we'll get better results. Primary prevention we are going to maintain the patient function. With tertiary prevention, we are just relieving the stress. At the end, could we reverse frailty in a practical way? Yes, we could. It's a mindset. Yes, the psychological issues are my decision that I will fight frailty will play an important role in these issues. Like Dr. William have said, a depressed person has the same genes before being a depressed person because of his losses, and he changed to be frail. What is really interesting is it is doable. It is doable. And even the anti-aging medicines is still coming from our food, our healthy food. The last thing I want to mention, there is a lot of researches in using the nano particles for treating these muscle masses, and there is other researches for gene therapy, but still the most promising things is the flavonoids and the medicine used for treatment, the chemotherapy for myeloid leukemias. Still, our choice to move and resist and increase and have better resilience is the main line of treatment for frailty. Thank you very much, and sorry for exceeding the time.
Thank you very much, Dr. Joey. Any questions?
Thank you very much for this important question. The main considerable points to choose this medication is the safety margin, to give the medication for safety margin. For they choose the safest medication possible, and they have and has been introduced since 2006, and there is a very good results. This is why they are very promising. This is why the Mayo Clinic Research Institutes working with these three medications, the flavonoids and the medication for the CMLL, having the best result because they know what we are going to happen in these issues. And still, there is no, they're still in the clinical trials. By the way, it's not an expensive medication. It's not that much expensive. I am deeply believed that the main line of treatment of frailty, of muscle loss, is mindset. Be high resilient. You will overcome it. I'm not with the medication, but this is promising result. There is a lot of other medication that cannot be discussed. Very expensive and another important time. If I'm going another important point, if I'm going to take this medication and I'm still not using my muscle, it's the same point like I'm taking the newest lecanemab medication for treatment Alzheimer, and it is disease-modifying medications. It's treating the Alzheimer patients. And if the patient is not using his brain, there is no need for this medication. No medicine will stimulate unused cells. But this is a very important point. Yes.
Thank you very much. Thank you.
Thank you, Professor Mohammed Shawqi, for the excellent talk. And now we move to invite our colleagues Rehab Ali Ibrahim to talk about rehabilitation of osteosarcopenia insight for clinicians. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank all the organizers and coordinators for their efforts and for giving me this opportunity. Regarding our topic today, rehabilitation of osteosarcopenia insights for clinicians. This is my agenda. So what is osteosarcopenia? The term osteosarcopenia emerged recently as a new geriatric syndrome referred to adults with increased risk of falls and fractures, secondarily weak muscles due to sarcopenia, and weak bones due to osteopenia or osteoporosis. Aging increases the risk of muscle wasting and bone mass loss. Regarding definitions, طبعا زي ما احنا عارفين كلنا الاوستيوبروزيس والاوستيوبينيا two conditions associated with decreased bone mass. Well, sarcopenia, according to the European Working Group on Sarcopenia, is low muscle strength and muscle mass. So osteosarcopenia is a coexistence of both together, osteoporosis or osteopenia and sarcopenia. Regarding history, sarcopenia was coined in 1989, and the term osteosarcopenia coined in 2009. The prevalence increases with age, especially in post-hip fracture patients. So why is the term osteosarcopenia emergent recently, and what is its importance? The fracture risk will increase to 4 times in those having osteosarcopenia عن ما يبقى في عندهم osteoporosis أو sarcopenia لوحدها. لدرجة إن هم سموها giant, a geriatric giant of the 21st century. Regarding pathophysiology, in the presence of multiple risk factors زي physical inactivity أو immobility, aging and low protein intake, بيحصل fat deposition in the muscles and the bones، وده بيؤدي بعد كده ان يحصل apoptosis in the myocytes and apoptosis in the osteoblasts او osteocytes, leading to increased risk of falls and risk of fractures. So who is at risk؟ في multiple risk factors. احنا هنركز عليهم اكتر طبعا الحاجات اللي هي ممكن تبقى correctable زي low body weight, الobesity, sedentary lifestyle, السموكينج, اللو فيتامين دي والجلوكوكورتيكويدز والdecreased calcium. Regarding diagnosis and assessment, finding cases is the most important. في flagging risk factors for finding the cases زي rate of annual falls, fracture history, clinical features of osteoporosis زي kyphosis أو shortage stature, clinical features of sarcopenia زي muscle weakness physical dysfunction. طبعا الالجوريزمز بتساعدنا في الموضوع ده. In many cases بقى ممكن العيان يبقى asymptomatic أصلا، فالريجولار assessment of bone and muscle mass والfunction in older people in the presence of risk factors is very important ان احنا نبقى oriented اصلا بالريسك فاكتورز. هنتكلم على الالجوريزم بعد كده. diagnosis of osteosarcopenia طبعا بيعتمد على diagnosis of sarcopenia according لليوروبيان working group on sarcopenia والdiagnosis بتاع الاوستيوبروزيس او الاوستيوبينيا بالدكسا. في حاجه بتساعدنا ان احنا to find the cases by SARC-F questionnaire عن طريق شويه اسئله كده اهوت، وبعد كده الكات اوف فاليو بتاعنا بيبقى more than or equal 4. الميجرنج طبعا بتاع الماسل سترينث using الهاند جريب دايناموميتر او التشير ستاند تيست. السكيلتال ماسل ماس كان بي measured using الدكسا، ده الجولد ستاندرد عندنا. لو مش موجود يبقى بايو الكتريك امبيدنس كان بي يوزد، بيقيس الابنديكولار سكيلتال ماس او الابنديكولار سكيلتال ماس اندكس when adjusted to height. لو هنستخدم السي تي او الام ار اي is more for research work. regarding الالجوريزم اللي قلنا عليه، طبعا to find the cases we can use SARC-F in the presence of risk factors. لو positive we can assess the muscle strength. If it is low then we are having probable sarcopenia, and in clinical practice this is enough to start treatment. For research work if we have to confirm sarcopenia we can assess the muscle mass using طبعا الدكس او bioelectric impedance او حتى ال MRI وال CT. If it is low therefore we are having sarcopenia confirmed. If we are having to assess the severity so we can use a physical performance test زي ال gait speed test وده بيأسس severity of sarcopenia. طيب is osteosarcopenia reversible؟ انا سمعت اسئله كتير عن frailty reversible ولا لا. بالنسبه للاوستيوساركوبينيا الفيزيكال اكتيفيتي والنيوتريشنال انترفنشن والابروبريت فارماكوثيرابي مثلا للاوستيوبروزيس كان هولد الاوستيوساركوبينيا، بس العيان مش هيرجع تاني للبيك بون او ماسل ماس اللي كانت عنده. عشان كده الايرلي دايجنوزس وايرلي تريتمنت از فيري امبورتنت. regarding studies have shown ان البوزيتيف ايفكت بتاع الاكسرسايز او physical activity بيديسابير within 6 months لو احنا بطلنا نعمل اكسرسايز. يعني ما ياخدش 12 جلسه مثلا وبعدين نوقف ويرجع ياخد تاني، لا ما ينفعش الكلام ده. هو البيشنت have to go on regular at home exercise program are recommended for long term periods. ليه بقى الاكسرسايز مهم؟ this figure is showing different pictures of MRI quadriceps. On the left side 40-year triathlete, 70-year sedentary man, and then 70-year athlete, and في significant difference in the intramuscular and subcutaneous adipose tissue as shown in the middle figure. واضح طبعا الفرق ما بين الاثنين، السيدنتري ميل يعني والتراي اثليت اللي على الناحيه الرايت. طيب ازاي بنعمل بريفنشن وثيرابيوتيك انترفنشن؟ طبعا زمايلي اتكلموا باستفاضه جدا عن التريتمنت اوف فريلتي والنيوتريشنال تريتمنت، دكتوره مروه اتكلمت عنها. فاحنا هنركز على الفيزيكال اكتيفيتي اللي هو الريهابيليتيشن بتاع العيان. طبعا he have to stop smoking لو هو سموكر. physical activity mainly بتبقى resistance and balance training and twice per week and not less than 30 minutes في السيشن. الفيتامين دي والكالسيوم in recommended doses والpharmacological treatment of osteoporosis والبروتين intake. So what is about rehabilitation osteosarcopenia? Our target is to reduce the fall and the fracture risk. ده المين تارجت بتاعنا. البيشنت education زي أي disease بنبدأ بالبيشنت education. The patient have to understand his own abilities. He can run, he can walk, he can climb the stairs. Movement adjustments زي turns or any other dangerous movement can be catastrophic and must be avoided. زي loaded forward flexion، يعني لو شايل حاجة تقيلة يحاول ما يوطيش لقدام لأنه ممكن يقع لأن البالانس بيبقى affected. twisting movements، extreme positions of distal joints والtrunk، forward flexion والextension. use of assistive device زي canes مثلا لو هو balance affected أو عنده osteoarthritis. اليوز اوف اورثوزيس زي الهيب بروتكتورز والسباينال اورثوزيس. الفيتامين دي والبروتين انتيك طبعا كل الدكاتره اتكلموا عليهم. طيب regarding بقى الاكسرسايز، الاكسرسايزز الميكانيكال لود طبعا بالفيزيكال تريننج بيزود الماسل ماس، وده بيعمل ستريس او ميكانيكال ستريس على السكيلتون، بيزود الاكتيفيتي اوف اوستيوبلاست. بس انهي اكسرسايزز هي اللي تعتبر اوستيوجينيك؟ هل اي اكسرسايز بيعمل لود يعتبر اوستيوجينيك؟ لا مش اي اكسرسايز. الفيزيكال تريننج اوستيوجينيك افكت must have a mechanical load applied على البون higher than during daily activities. يعني المشي لوحده مش كفايه، السويمنج مش كفايه، لازم تبقى حاجه اسمها هاي ويت امباكت اكسرسايزز زي الجامبنج والجوجنج وطبعا معاهم progressive resistance exercises alone or in combination. دول ممكن يحسنوا الموفمنت. طبعا انا عارفه ان الجيرياتريك مش هيقدروا ينطوا ويجروا، بس يعني ممكن تو كلايم ذا ستيرز، او ممكن نعتمد بقى على resistance exercises. بس الجيرياتريكس يعني بره بيعملوا الحاجات ديت الحقيقه. ماشي. طب ايه الهاي امباكت ويت اكسرسايزز؟ زي ما قلنا الراننج والفوتبول والتنس والباسكت بول، بس طبعا الحاجات دي بتبقى لايف ستايل موديفيكيشن. يعني الاكسرسايز ان ساركوبينيا اللي هي بتمبروف الماسل ماس، طبعا بيحصل لوس اوف او ريدكشن اوف ماسل ماس بتوين السكند والايتس ديكيد، بالذات افتر ولا ريالو. بقول لحضرتك. طيب تمام. الاكسرسايز ان ساركوبينيا زي ما قلنا الريزيستنس تريننج وبالانس اكسرسايز دول كورنر ستون اوف تريتمنت، علشان الريزيستنس تريننج بتحسن التايب 2 ماسل فايبرز، ودول المسؤولين ان هم انكريز الماسل سترينث. والبالانس طبعا تريننج يحسن الموفمنت. therefore الاكسرسايز ان اوستوساركوبينيا should be focused on muscle strengthening اللي هي الريزيستنس اكسرسايز اللي هي تمارين المقاومه بويتس، والويت امباكت اللي هي الهاي امباكت اكسرسايز زي ما قلنا، والبالانس تريننج. الاكسرسايز بروجرام فور اوستيوساركوبينيا بنبدا بالورمينج اب زي شويه ستريتشز اند ووكينج. then اللور ليمب سترينثنج اكسرسايز ده اكزامبل السترينثنج اكسرسايزز ويز اسيستد تشير، الهيب ابدكتورز يوزنج التشير ويوزنج السيرابانز موجوده تحت في الصوره اللي تحت. واعتقد في سلايد عدت هو اصلا وده بيعلق شويه بس. طيب تمام، عشان السلايد ديت بس فاتت. الماتيريالز تو يوز during السترينثنج اكسرسايز طبعا التشير، ممكن يستخدم الوول، ممكن الاستيك بانز، ممكن حتى بوتل اوف ووتر لو ما فيش ويت. التارجت ماسلز اهم ماسلز المفروض نعمل لها سترينثنينج اللي هي الماسلز الاراوند الجوينتس اللي بتبقى لايبل ان هي تبقى فراكشر زي الهيب او السباين. طيب regarding الماسل سترينثنينج في الابر اكستريميتي، هنا مثلا اكزامبل الماسل سترينثنينج للبايسبس ماسل يوزنج الويتس، وللترايسبس ماسل يوزنج الويت ويوزنج الالاستيك بانز اللور. طيب النيورو ماسكولار ستيميوليشن، لو عيان مش عاوز يعمل exercises، سواء هو مش قادر unable to do these exercises او not willing to do exercises، ممكن نستخدم حاجه اسمها نيورو ماسكولار electrical stimulation. ده بيزود الماسل كونتراكشن ودوت بيحسن البروتين سينثيسيس بعد كده. هو البالانس اكسرسايزز طبعا في عندنا التاندم ووكينج، ممكن يبقى العيان سبورتد، وفي البالانس اون وان فوت يوزنج تشير. الفلكسبيليتي اكسرسايزز مهمه لان العيان طبعا ممكن يبقى عنده ريجيديتي، والريجيديتي دي ممكن تاثر على الموفمنت بتاعته فيزود الريسك اوف فول، فبنحب نعمل برضه فلكسبيليتي اكسرسايزز. طيب هاو تو ميجر الاوتكم؟ طبعا يوزنج نفس الحاجات، الدكسا سكان فور ماسل ماس، والماسل سترينث يوزنج الجريب سترينث والايزومتريك ني اكستنشن، والجيت سبيد فور فيزيكال بيرفورمانس. وفي حاجه عندنا اسمها الموديفايد بارسل اندكس اللي هو بيأسس الاكتيفيتيز اوف ديلي ليفنج. الالجوريزم ده بيلخص بس في الاخر كده المانجمنت اوف ساركوبينيا، كل الكلام اللي قلناه بس هو متلخص في نفس الفيجر هنا. هو لو عندنا عيان عنده ريسك فاكتورز والسارك اف بتاعه بوزيتيف، هنعمل ابلاي الساركوبينيك الجوريزم، وفي نفس الوقت هنعمل له ديكسا. لو اوستيوبروتيك هيتعالج كاوستيوبروزيس، لو هو عنده ساركوبينيا هيتعالج كساركوبينيك. لو عنده الاثنين كونديشنز هنبدا بقى نعمل البروتوكول بتاعنا اللي هو بروجريسيف ريزيستنس وبالانس اكسرسايز والنيوتريشنال سبلمنتيشن والانتي ريزوربتيف انابوليك دراجز اللي هي زي الدينيوسيماب. دوت بيبقى ليه افكت كويسه قوي على الماسل وعلى البون برضو. وبنعمل ري اسسمنت every 1 year. التيك هوم مسج: awareness about osteosarcopenia among patients and medical professionals is very important, especially that it is usually asymptomatic. الفلاجنج ريسك فاكتورز لازم نبقى oriented بيها. we can use السارك اف questionnaire. البون density والlean muscle mass والmuscle function should be routinely evaluated in patients with high risk. Resistance and balance treating nutritional intervention and osteoporosis medication are effective in limiting osteosarcopenia. And thank you.
Thank you, Dr. Rehab, for this excellent presentation about osteosarcopenia. Any question, please? Yes.
انا والله مبسوطه ان انا مع حضراتكم على طول، عندنا تعاون كده علمي وعملي ان شاء الله يعني. أيوة. هي مشكله العيانين اللي هم روماتولوجيكال او عندهم سواء اوستو ارثرايتس او روماتويد ارثرايتس، اصلا الاسسمنت بتاعهم بيبقى صعب لان هم ان بين، فدوت بيأثر اصلا على الاسسمنت تولز بتاعتنا. فبنحاول نعمل الاثنين مع بعض، ان احنا نعمل تريتمنت للاوستو ارثرايتس نفسها، وهي الاوستو ارثرايتس نفسها في التريتمنت بتاعها بيبقى فيه سترينثنينج اكسرسايزز اللي هي الاستراتيك كوادريسبس اكسرسايز، والكوادريسبس ماسل دي هي اكتر حاجه غالبا بتبقى افكتد برضو في الساركوبينيا. فهنعمل تريتمنت للاوستو ارثرايتس، وهنعمل برضو نفس البروتوكول بتاعنا اللي هو الريزيستنس والبالانس تريننج. التريتمنت بتاع الاوستو ارثرايتس بقى اللي هو عادي برضو في فيزيوثيرابي بتاعنا، لو محتاج بقى جوينت ريبليسمنت هيروح. نعم. لا الهاي امباكت هي انا عارفه ان هي مش ابليكابل قوي عندنا هنا هوت، يعني الهاي امباكت دي علشان تتعمل لازم يكون العيان دوت اصلا كان الفيزيكال بيرفورمانس بتاعه يساعده في حاجه زي دي. احنا العيانين هنا عندنا جيرياتريك عاوزين نوديهم يعملوا انفستيجيشن مش راضيين يروحوا اصلا، فهنعتمد على الريزيستنس اكسرسايزز اكتر هنا والبالانس تريننج. والريزيستنس اكسرسايزز مش بس بتاثر على الماسل، بتاثر على البون كمان، يعني كل ما بنحسن الماسل باور هنحسن البون برضه. تمام ماشي.
There is other question. Just to comment, to underline, Rehab, that the role of multidisciplinary team is very important.
I can't,
Yes, to join physical and nutritional intervention and to improve osteosarcopenia. Not only geriatrician, but all the team can help. And we can start with hospital day or before leaving the hospital, the program, and then continue if they leave the hospital.
Yes, the patient, as I understood you, you are asking about the patient education protocol. Yes, we can give the patient, as patients, geriatric patients, it's difficult to get out of home frequently. So we can give them some exercises to do at home, or physiotherapists can go at home also and do. The most important is the maintenance. The patient has to do the exercises at least 3 times per week and 30 minutes for session. This is the most important. Thank you.
Thank you, Professor Rehab. Thank you. And I'm pleased to introduce our dear guest from Tunisia, Professor Sonia Hammam, Professor of Internal Medicine at Montasser University, Tunisia, and she will talk about new management of sarcopenia. Welcome, Professor Sonia. We are happy to have you with us today.
Thank you. Thank you for the organizing committee to invite me. It's a really pleasure to be with you and to present today management of sarcopenia. So I will talk after definitions, the mechanisms of sarcopenia, how we can identify sarcopenia, the consequences, and finally the intervention. So there is a lack of widely accepted definition, clinical definition or practice definition for geriatrician. And it's important before starting with sarcopenia and with the definition of sarcopenia to know the origin of the terms sarcopenia. It's a Greek word which sarx means meat and penia means loss. For definition, initially in the last decade, the working European group in sarcopenia helped a lot of clinicians for the first definition of sarcopenia. And 10 years after, they proposed a revision of the criteria of sarcopenia, and they proposed 3 stages for sarcopenia. Presarcopenia, which means the decrease in strength of muscle, and sarcopenia, which means decrease in both muscle strength and muscle quantity and quality. And finally, severe sarcopenia, which means the decrease in muscle strength, muscle quantity and quality, but also in physical performance. And recently, the Global Leadership Initiative on Sarcopenia, GLEAS, in 2024, it's really recent, they published this paper about a new concept in sarcopenia. And this new concept helped a lot. The group concerned 3 items to define sarcopenia: the muscle mass, the muscle strength, and muscle-specific strength. In this paper, the group underlined that physical performance was accepted as an outcome, not as a part of the definition of sarcopenia. It's a consequence of sarcopenia rather than a component of sarcopenia. What about mechanisms? Recently, we consider sarcopenia as a muscle disease. It is associated with muscle failure, and this phenomena increases with age. It's really associated with older age. But sometimes we have some cases of sarcopenia earlier in life when they have some comorbidities like diabetes or hypertension. Huge risk factors for sarcopenia and for older adults. But we can specify the risk factors in 2 groups. The first one is non-modifiable risk factors, and the second one is the modifiable risk factors. Like environmental factors, like metabolic risk factors, and behavioral states. For non-modifiable risk factors, age is the principal risk factor for sarcopenia. So as you can see in this slide, no other cause is evident but aging itself. And this slide shows the difference between the muscle mass when we are young and the muscle mass when we get old. This is closely related to the body composition. With age, the lean mass decreases and the fat mass increases. And as a result, we have sarcopenia. And this study shows clearly the decrease in muscle mass with age and the increase of the prevalence of sarcopenia in both sexes, but it is more frequent for women compared to men. The etiology of sarcopenia is multifactorial, and the aging process leading to sarcopenia can be associated to some sex hormones like testosterone or estrogen, hormonal dysregulation like insulin resistance or growth hormone dysregulation, other factors like genetic susceptibilities, apoptosis, and also mitochondrial dysfunction. So sarcopenia and the loss of muscle mass is related, first of all, to the age. But as I said, there are other risk factors related to the decrease of physical activity, which means the disuse, related to comorbidities, and you know that most of older adults have more than 7 diseases in the same time and took many medications. So like diabetes, like hypertension, cardiac failure, and all comorbidities can increase the prevalence of sarcopenia. All diseases associated with hypermetabolism, all infections with inflammation, with an increase in cytokines, because inflammations, as my colleagues said, increases the risk of sarcopenia and decrease the muscle mass. And increased cachexia, which is closely related to sarcopenia. Other factor to consider is the lifestyle, environmental factors, smoking, alcohol intake, all those increase the risk of sarcopenia. So aging increase the primary sarcopenia, and the function of our muscle decreases early in the time, maybe in 20 or 30 years, we start the decrease in muscle mass. But most of the time we have primary and secondary sarcopenia associated to the decrease in physical activity, to diseases, also to malnutrition, and all those increases the risk of immobility, of dependency, and the risk of decrease of activity of daily living. How we can identify sarcopenia? It's really very easy to use this test, SARC-F, to assess, to have easy assessment of sarcopenia in older adults. With high sensibility and high specificity, it includes 5 items, as you can see here. And if we have more than 4 points, it's really predictive of sarcopenia. We can identify sarcopenia with some measurable variable, like we can measure the mass of the muscle, the strength, and the physical performance. So for the muscle mass, we have a wide range of body imaging technique, but most of the time we use it for research. But it's more easy for us to use anthropometric measures or ultrasound, which is not really costly like MRI, for example. For muscle strength, we can use hand grip strength or knee extension strength. For physical performance, we have a wide range of tests to measure physical performance. The usual gait speed, very easy to interpret, measure the time required to walk 4 meters at a normal pace. And if we have more than 6 seconds, it is considered as predictive of sarcopenia. The second test is get up and go test. If the test have more than 20 seconds, means the person needs assistance and there is a high risk of sarcopenia. The other test is the chair stand test. And for the chair stand test, we ask the patient to measure, we ask the patient to do 5 rises from a chair. And if the time is more than 15 seconds, it's considered as a high risk of sarcopenia. And the last one is the balance test. And after all those tests, we can present as recommended by the European Working Group the algorithm which helps a lot clinician to the first step to diagnose sarcopenia and then to intervene. So to find cases, we can use only SARC-F, which is very easy with the 5 items. Then we can assess the muscle strength with the grip strength and chair stand test. If sarcopenia is very probable, we can confirm with muscle quantity or quality with MRI as an example. And to confirm, we can use to confirm sarcopenia, and to assess the severity of sarcopenia, we can use the gait speed test or time and up go test. What about consequences? For sarcopenia, we have a huge consequences related to the frailty, as frailty is closely associated to sarcopenia. So we have a decrease in immunity, we have an increase in infections, an increase in osteoporosis, and by the way, the increase of falling and the increase of fractures. And by the same process, the decrease of physical activity, which helps a lot for falling and for the high risk of fracture. So sarcopenia and frailty are really closely related, and there is a bidirectional association. And most of the time they are associated with a poor outcome and decrease in quality of life. This slide shows again the concept of osteosarcopenia that my colleagues really explain in the last lecture. And this illustrates the relation between osteoporosis, sarcopenia, and frailty. If there is intervention to help for and to improve sarcopenia, if there is a reversibility, yes, by using exercise therapy and by using nutritional therapy. There are some other studies that underline the role of hormonal replacement and some pharmacological treatment like metformin or angiotensin converting enzyme inhibitors. So it's possible, it's a reverse phenomena. We can, with physical and nutritional activity, we can help a lot our, this is an example of project in Belgium to help with the rehabilitation unit to help patients. And before concluding, the Mediterranean diet pyramids, which helps a lot, also for osteopenia, for osteoporosis, and also for sarcopenia. So we conclude to say that prevent is better than a cure for even sarcopenia or osteoporosis or frailty. Thank you for your attention.
Thank you, Professor Sonia, for this impressive talk. Any question for Professor Sonia? Okay, but let us stress that prevention is the cornerstone modality for treatment of sarcopenia and frailty. Thank you. And it's a pleasure to introduce our colleague, Dr. Hisham Mosad, lecturer of geriatric and gerontology in Shams University, and he will talk about frailty in palliative care.
Bismillah ar-Rahman ar-Rahim. It's a pleasure to be with you today. I'd like to thank the chairpersons, my colleagues and professors. We'll jump over
We'll jump over the definitions today, as it had already been mentioned in the previous lectures. The core of our talk today is about frailty in palliative care. It is a slowly progressive condition. In early stages, some components can be controlled in early stages. Unfortunately, in late stages that are seen in hospice and late stages of palliative care, the condition is mostly irreversible. This is not against what Dr. Shawi had said, because it is concerned with the late stages of frailty. It is concerned with multiple domains in palliative care, concerned with cognition, concerned with function, psychological issues, and somatic issues. The prevalence is striking in elderly, 11% over 65 years old, and striking figure of 25 to 50% over 85 years. As a matter of fact, higher numbers are expected in palliative care patients and in lower income countries. Our first important question, can frailty represent a condition that triggers palliative care interventions? Palliative care, of course, is induced and called for by cancers, chronic incurable conditions. These are the most common triggering conditions. But as frailty alone, it is mostly overlooked. Up till now, it is somewhat vague to be applied clinically alone to induce palliative care interventions. Variations in frailty definitions and methods of diagnosis somewhat hinder this referral for frailty alone. Just have a look at the eligibility criteria for palliative care consultations. It is a group of medical conditions, a comprehensive list. Metastatic cancers with failure of multiple regimens of treatment, neurological complications of cancer, brain metastasis, spinal cord compression, passing by advanced cardiac diseases requiring consideration of interventions, advanced renal disease, neurodegenerative disorders, strokes with residual functional impairment of over 50%. You cannot find frailty. In fact, frailty is found in every and each diagnosis of these, but it may be a consequence and an integral part of these conditions. Palliative care is not only concerned with medical conditions, but also with situations of uncertain prognosis, uncertain appropriateness of therapy, uncertain end-of-life status and hospice appropriateness, declining function with decreased ability to complete activities of daily living, and unrelenting and unexplained weight loss. All these situations are found in frailty. You can conclude that frailty is a component of every palliative care patient, or at least most palliative care patients. However, most of these patients are lost in palliative care services. They do not receive what they deserve in palliative care. To bypass this myth, you have to make palliative care referral for frail patients as a spectrum, not a mere diagnosis. As the needs increase, as the number of comorbidities increase, as disabilities increase and symptoms increase, this is the place of palliative care for frail patients. Palliative care referral benefits the patients of frailty for fulfilling the needs tailored based on their condition, diagnosis, and chronic illnesses. Never consider palliative care to be just an area of end-of-life care. Palliative care should start hand in hand with the primary diagnosis of frailty. As frailty is diagnosed, then refer for palliative care to control the symptoms. The process of referral for palliative care is triggered by two methods, either the diagnosis-based trigger or the prognosis-based trigger. The diagnosis-based trigger is easily applied in cancer patients. Once the cancer diagnosis is done, palliative care is called for. It is widely accepted in cancer patients by the oncologists and patients themselves. The other trigger is the prognosis-based trigger, which is more suitable for the chronic life-limiting conditions. Neither of those is suitable for frailty. Frailty is best to be referred by the needs-based trigger. This means as the needs of the patient increase, then the referral for palliative care would be suitable. These needs are along three domains: burdens and symptoms, psychosocial needs, and functional dependence. You can assess these needs at every point of contact with the patient, whether during hospital admission, long-term care admission, or outpatient settings. Let's take a step forward in our talk with the hospice care. Actually, hospice care is a part of palliative care. It aims for comfort care at the end of life care. When the life expectancy is 6 months or less, then this is the place of eligibility for hospice care. Hospice care is not equal to palliative care. This is the second important question. Can frailty alone trigger a hospice care referral? Can you expect a 6 months life expectancy because of frailty alone? Do we yet have a group of decisive criteria for hospice admission for frail patients without other comorbidities? It is well known that chronic life-limiting conditions have a preset, clear-cut criteria for hospice referral. Cardiac illness with congestive heart failure, inability to carry out minimal physical activity despite optimally treated with anti-failure medications, recurrent angina, these are eligibility criteria for hospice. Liver diseases, end-stage liver disease with cut points for PT, INR, albumin, and refractory symptoms are eligible for hospice. What about frailty? Actually, frailty lacks these solid criteria for two main reasons. The first is heterogeneity of the frail patients. They are not the same. Some live with functional or sensory impairment and experience just a slow downward health trajectory. Others have other comorbidities that will make their prognosis worsening in a quick fashion. So the group of patients with frailty is heterogeneous. The second is the disease trajectory. Disease trajectory of frailty is slowly progressive deterioration, which means there is difficulty to locate a single point to refer to hospice care. Along this graph, you cannot predict which point there is a 6 months life expectancy. What about function? Can you predict mortality through function? Only through functional deterioration to detect a 6 months life expectancy? According to studies, the answer is no. Over 900 patients were included in a retrospective study in the last year of life. Their function was deteriorating regarding bathing, feeding, mobility, and continence. But there is no special course along the last 3 months or 6 months. This means that the progression in frailty is expected to be linear as this approaches. So you cannot predict a 6 months life expectancy with frailty alone. Assessment of frailty is best to be done through the comprehensive geriatric assessment, assessing the 5 main criteria or domains of medical, psychological, functional, social, and home environment. There is intersection between frailty in palliative care and geriatric medicine. In general, palliative medicine and geriatric medicine intersect in 2 main issues: the comprehensive approach with multidisciplinary teams, and both medicines aim to treat patient as individual and incorporate family into the care. Who should take care of frail patients? Is it geriatricians or palliative care? In early cases, where there is much to be reversible, geriatricians take the upper hand. In late cases, where there is least to be reversible, and with refractory and persistent symptoms, then palliative care should take the upper hand. Palliative care focuses on a number of symptoms that are beyond the geriatric point of view, or more concerned with palliative care, even if some of them is common geriatric medicine. Symptom control is most important. Screening for the most common symptoms in frail patients: weight loss, pain, dyspnea, falls, depression, and insomnia. Accurate prognostication of the patient, good communication with family and caregivers, good decision making, facilitating the process of decision making, and avoiding polypharmacy. Speaking about polypharmacy, we follow the golden rule of starting low and go slow. But very important, palliative care is to get there. You have to be somewhat liberal with medication use, especially in hospice patients. Your first and primary target is to control symptoms, even with some acceptable side effects. Cognitive frailty is really a challenge in palliative care. It hinders communication, which is a cornerstone of palliative care. It leads to lack of reporting of symptoms, integral in palliative care management like pain. Unfortunately, cognitively impaired individuals receive their care outside palliative care centers, mostly in homes, hospitals, nursing home facilities, leading to less access to palliative care services. Advanced care planning is integral. It is a process that supports people to understand and share the personal values and receive the care according to these values. Unfortunately, frail older adults are often spoken for than spoken with. Advanced care planning should start early, especially in frail patients. This is to give enough time for decision-making and to undertake advanced care planning while the patient has still the capacity to express their values and take decisions based on these values. Advanced care planning can improve a better individual experience, align treatment with individual's preference, avoid unwanted and costly invasive treatment near end of life, improve psychological outcomes for family members during bereavement, reduce stress and anxiety and depression in surviving relatives. Unfortunately, advanced care planning in Egypt is massively overlooked. Physicians are unsure of what to say, they lack training for needed communication skills, with marked deficiency of formal legality plan to protect physicians from legal penalties. Symptoms in palliative care for frail patients, the burden of symptoms even matches that of cancer patients. Pain is very common in frail patients, 30% in the last 2 years of life, 50% over the last month. Pain distress with frailty is similar to that of COPD, end-stage renal disease, and ALS. Dyspnea in frail patients and fatigue is more than non-frail patients. Palliative care is concerned with needs together with symptoms. Psychosocial needs are very common in frail patients in palliative care. Frail patients experience similar emotional distress to people with cancer. Frail patients have the lowest perceived social support, hope, and highest desire of death. A study in palliative care unit in Spain declared that emotional stress was suffered in 42% of patients with cognitive frailty and 25% of frail without cognitive impairment. Functional needs are also substantially high. During the 9 to 12 months prior to death, functions of bathing, feeding, mobility, and continence showed high level of dependence. Levels was even higher with cognitive frailty. Frailty and cancer. Frail elderly patients are the largest proportion affected by cancer. Frailty and pre-frailty reaches a prevalence of 42 and 43%. However, these are the least enrolled population cancer trials because of the lack of standardized outcome-based risk stratification algorithm that guide the treatment protocols. Stressors on frailty cancer patients are both imposed by the cancer itself and its treatment. The assessment of cancer patient for oncological management plan is not enough to be according to chronological age. We have 3 models of assessment: the phenotype, the cumulative, model defines frailty as the cumulative effect of individual deficits, which are clinical signs, symptoms, disease states, disabilities, and abnormal laboratory test results. The most important is a comprehensive geriatric assessment, a multidimensional, multidisciplinary approach to the patient. It was recognized as the best in clinical practice for identification of frailty in cancer patients. It has also been applied more recently in geriatric oncology settings. The role of comprehensive geriatric assessment in cancer patients is to detect the deficiencies, functional, cognitive, nutritional, comorbid condition, classify patients as fit or frail, and risk stratify for treatment regimens. Mostly, they lead to less aggressive management measures. When dose reduction was recommended based on comprehensive geriatric assessment, it was found that it leads to better tolerance with same rates of disease control. The benefits of comprehensive geriatric assessment for frail cancer patients: 28% of treatment decisions were affected by comprehensive geriatric assessment toward adjusting type of treatment according to occupation condition. Non-oncological interventions were suggested according to social issues, nutrition plan, and polypharmacy. Comprehensive geriatric assessment lead to completion rates of treatment, less treatment-related toxicity and complications. However, effect on mortality is still not proved. Comprehensive geriatric assessment outweighs all the sensitivity and specificity of the mere screening tests of frailty, including the VAS-13, G8 scale, triage risk screening tool, GFI index, and Freud frailty criteria. Frail patients are increased risk of all-cause mortality, post-op mortality, chemotherapy intolerance, and post-operative complications. My take-home message is most importantly about frailty and palliative care patients is a spectrum rather than a syndrome. Hospice care should focus on symptom control rather than accurate prognostication. Comprehensive geriatric assessment is a gold standard tool for management of frailty and suitable interventions. Frailty is a syndrome that should be shared between geriatrician and palliative care interventions. It is well worth to improve the advanced care planning in Egypt by providing better regality plans for physicians. Thank you.
Any question for Dr. Hisham?
Thank you, Dr. Hisham. Just a comment for patients, older adults with cancer. I think as you underlined, comprehensive geriatric assessment and the intervention of geriatrician is very important. We talk about orthogeriatric, we talk about psychogeriatric and oncogeriatric, maybe is very also important, and we need to start this collaboration, because without the multidisciplinary evaluation, we can't have really a good outcome. And we need to start early to have a good outcome for our patients with neoplastic problem. Thank you.
شكرا دكتور هشام. وطبعا الميزه بقى احنا عندنا في الجيرياتريكس احنا جمعنا بين البالياتيف كير اند جيرياتريك كير في البالياتيف جيرياتريك بالياتيف كير يونت، فالابر هاند هتبقى للجيرياتريشن في البالياتيف كير وفي الكجيرياتريشن. I would like to welcome Dr. Sayed Al-Ghunaimi, Professor of Physiology, who is going to talk about pathophysiology of frailty in diabetic patients.
Thank you, Professor Manar, and thank you, my chairpersons. Firstly, what is the definition of frailty clinical syndrome? As Professor Hisham said, characterized by involuntary weight loss, exhaustion, muscle weakness, slowness of gait, and decreased physical activity. Some authors include psychological components as a frailty component. In a physiological basis, this situation characterized by extreme vulnerability to effects of low-intensity stressors that result from difficulty in maintaining homeostasis. Frailty is a manifestation of disorders in different systems of the body, including CNS, endocrine, immune, musculoskeletal, cardiovascular, respiratory, and renal system. Frailty is the main predictor of disability and dependence mortality in elderly. But the good news is it is a potentially reversible condition. What about prevalence? Around 14% of elderly population has a frailty. What about the relation between frailty and diabetes? Really, it is a bi-directional relationship. Frailty can lead to diabetes, and diabetes can lead to frailty. What about the pathophysiology of frailty in diabetics? First of all, there is hormonal imbalance. Diabetes is a state of insulin resistance and insulinopenia. And as we know, that insulin is anabolic hormone. So insulin deficiency can lead to sarcopenia and muscle wasting. Also, the defect in insulin can lead to decrease in insulin signal transduction pathway and mitochondrial alterations, and affecting the muscle energetics and lead to weakness of the muscle. So insulin deficiency can lead to weak muscle and muscle wasting also. another hormonal imbalance at the level of hypothalamic pituitary state, there is decrease in insulin growth factor 1 and the growth hormone level in diabetics, and also this is anabolic hormone. So loss or decrease in insulin growth factor 1 will lead to muscle wasting. There is a defect or well-known defect in hypothalamo-pituitary gonadal axis, and uncontrolled diabetes can be associated with hypogonadism, and testosterone also one of the anabolic hormone that involved in protein synthesis and satellite cell formation. So this will lead to muscle weakness and sarcopenia. Regarding inflammation, uncontrolled diabetes considered as an inflammatory condition, and it is associated with increase in the inflammatory biomarkers such as TNF-alpha and interleukin-6. Both of them or all these inflammatory biomarkers will lead to sarcopenia. What about the advanced glycated end products? Not hemoglobin A1C is the only, hemoglobin A1C is not the only glycated end products, but there are many advanced glycated end products produced by the non-enzymatic interaction between glucose and the other proteins. These advanced glycated end products can lead to sarcopenia through the affection of the muscle microcirculation and affecting the endothelial cells of this microcirculation. Also, it can induce inflammation and also can interact and form a cross-linking with collagen in the skeletal muscle, inducing sarcopenia. What about the cognitive decline in uncontrolled bronchidiabetes? Diabetes can associated by a low grade of depression, and depression can lead to also dementia and frailty. Cognitive dysfunction can have an impact on both hypoglycemia and hyperglycemia, and also there is a bidirectional relationship between dementia and hypoglycemia. A very common presentation in elderly diabetics, especially those in sulfonylurea, is hypoglycemia. Hypoglycemia is a very injurious to the brain cells and can lastly lead to dementia and cognitive dysfunction and frailty. Also, cognitive dysfunction or frail patient, when developed dementia, hypoglycemia or the another attacks of hypoglycemia becomes more profound. So hypoglycemia leads to frailty. Frailty will worsen the pre-existing hypoglycemia or the next attacks of hypoglycemia. Especially in elderly population, the hypoglycemic attacks usually it is underreported and less recognized. Hypoglycemic attacks usually under-recognized and less reported. Why? Because of the non-classical presentations of hypoglycemia. The common manifestation of hypoglycemia is adrenergic symptoms such as tachycardia and sweating. But usually the elderly diabetics come Usually, the hypoglycemic attacks in elderly diabetics come by neuroglycopenic manifestations, which is a severe manifestation. Why neuroglycopenic manifestation is the presentation of hypoglycemia in elderly diabetics? Because of a state of autonomic neuropathy that will blunt the adrenergic response to hypoglycemia. So hypoglycemia in elderly population have a serious consequences and can lead to lastly to dementia. So according to American Diabetes Association, it recommends to use continuous glucose monitoring device in elderly diabetics above 65. Another mechanism or another pathophysiology that is incorporated in the mechanism of frailty in elderly diabetics is falls. The incidence of falls increased in diabetics because of peripheral neuropathy and loss of balance, and also because of vascular disorders due to premature atherosclerosis. Also, cognitive dysfunction can lead to falls. Falls associated with morbidity and mortality, especially the fractured neck femur. What about anti-diabetic medications and frailty? Can the anti-diabetics lead to frailty? Yes. Sulfonylurea, one of the common mistakes or the bad mistakes is to use sulfonylureas above 65, commonly associated by hypoglycemia, especially elderly diabetics has a loss of appetite, have decreased estimated GFR and chronic kidney disease. So we should avoid using of sulfonylureas above 65. What about thiazolidine diones, bioglitazone? Bioglitazone increases risk of osteoporosis and also increase risk of heart failure. So better not to be used in elderly diabetics. What about sodium glucose transporter 2 inhibitors? It can increase urinary incontinence, although it is one of the best medication in the diabetes management, but can induce incontinence, and some groups or dapagliflozin can increase risk of fracture, so we should use it cautiously. What about GLP-1 receptor agonist? One of the recent publications published by Professor Osama Hamdi, professor of diabetes in Harvard University, is that GLP-1 receptor agonist in elderly can induce sarcopenia and frailty. So when we use this medication, we should use it very cautiously. This is the most of the mechanisms involved in frailty and diabetics. Why we mentioned these mechanisms? These mechanisms will lead us to the prevention. When I treat the diabetes very early and tightly, I can prevent frailty. When I treat also the diabetes and prevent the attacks of hypoglycemia, I can also prevent the frailty in elderly diabetics. What about the management of diabetes in frail patients rapidly? Exercise is a very important issue, and the nutritional intervention, especially protein intake and the energy intake. Also, Professor Osama Hamdi said that we should increase the protein in the meal of elderly diabetic, especially on GLP-1 receptor agonist, to avoid sarcopenia. What about the pharmacological treatment? Firstly, when starting pharmacological treatment, the principle of start low and go slow is very important to avoid the attacks of hypoglycemia. Cautious use of insulin and metformin, and mindful of renal function. I'd like to say that creatinine is a bad marker of kidney function. Actually, most of us use creatinine and urea. American Diabetes Association recommended to use renal functions and estimated GFR. For example, 65 years old male presented to our clinic by creat 1.2. Some doctors consider this as normal. Really, estimated GFR around 40. Around 40. So creatinine is a bad marker of kidney function. We should assess for estimated GFR. De-intensification regimen, usually in our lectures, we talk about we should intensify our regimen in diabetes management. But in elderly, frail patients, I say about de-intensification regimen, especially in elderly diabetics with multiple complications and reduced functions. Why? As elderly diabetics usually overtreated. Discontinuous sulfonylurea and short-acting insulin and we can use DB4 inhibitors and rapid-acting insulin, avoid TZDs. So my home messages, frailty is the main predictor of disability dependence mortality. Prevalence is around 40%. Frailty appears to be dynamic and can be reversed. Early recognition of frailty and early intervention should be the major issue for our general practice. Dysglycemia, either hyperglycemia or hypoglycemia, can induce frailty. We should assess the functional dependency in diabetics. Avoid hypoglycemia in cognitive impairment. We should select the proper anti-hyperglycemic therapy carefully to avoid the hyperglycemia and hypoglycemia. We should individualize the glycemic target. Some can consider the A1C for his father or her mother around 7, it is good. One size doesn't fit all. We should consider A1C according to the patient condition. In elderly, frail diabetics, we can consider it as the target of us to avoid the attacks of hypoglycemia. And thank you so much.
Thank you so much, Dr. Sayed. Any questions?
Thank you, Doctor, for this excellent conference. My question is about metformin as a treatment for diabetic patients to improve sarcopenia, according to the profile of patients, because there are some studies talking about this treatment and the positive effect for muscle mass.
Really, metformin, I have no... I agree to use metformin, especially after estimation of GFRs firstly. Second, I can use it. It can improve insulin resistance, so can improve to a little extent sarcopenia. I can consider it really in my practice, but should estimate GFR firstly.
Thank you very much, Dr. Sayed, for your existence with us.